Okay, today what I will be speaking will be about the resuscitation in children and infants. In the previous classes, you have already heard about the cardiopulmonary resuscitation in adults. So as you know that CPR is a series of life-saving actions which follows after a victim fall into arrest. So recognizing the condition early and identifying the cause is of utmost importance because time factor plays a very important role. So we will come to the resuscitation in children and infants. So first we should know what is the category of adult children and infants. So children is, as you all know, it is from 1 year to age of puberty. That is children. Infants is less than 1 year. When you say children from 1 year of age to puberty, you should know what are the signs of puberty. So enlargement of breast in females and the presence of underarm hairs in males is considered to be the puberty age. So children from 1 year of age of puberty to infants less than 1 year. Now we are focusing on the main differences resuscitating an adult as well as a child. So we will go for the pulse check. Usually you all know that pulse check in an adult patient who is in cardiac arrest, it is by carotid pulse. But here in an infant, because it is very chubby, you will not be able to feel the pulse. So they say brachial pulse. In infant, brachial doesn't mean here in the cubital fossa, it is between these two muscles so that we can easily palpate. In a child, either you can check the carotid or the femoral, because the child, the age is from 1 year to 12 years. So you, like in a bigger child, you can always palpate the carotid pulse. And in a child, with a small child, femoral. So in a child it is femoral and carotid, and infants it is brachial pulse. Hand placement is very important. In an adult, you know, that is lower half of the sternum with the two hands you are going to do, but here it is a 2-finger technique and 2 thumb encircling hands. So I'll show you the picture. So that is about the brachial pulse. Where are you going to check in an infant? And see, that is what you see here is a 2-finger technique. That is the lower half of the sternum you are doing, and this is the thumb encircling hands method. Here, if you ask which one is better, it is the thumb encircling hands method, because you are compressing at all areas so that the perfusion will be much better. So this is a compression in a child with a one hand. So if it is a small child, you can use one hand. If it is a bigger child, you can go for 2 hands also. And here, what is the depth of your compression? In adults, you know that it should be at least 5 centimeter or 2 inches. In a child, what we say is like you should compress 1/3 of the anterior posterior diameter of the chest. That is in a child. In a child, if you say, it will be approximately 5 centimeter, and in an infant it is 4 centimeter. So that is about the depth. Now coming to the ventilation, so there are, like you know that it is mouth-to-mouth ventilation, mouth-to-mask ventilation, and back mask ventilation. Mouth-to-nose, here it is mouth-to-nose and mouth breathing. So in an infant, it will be difficult actually to resuscitate a baby giving mouth-to-mouth because it is too small. So you have to include the nose also while you are giving mouth-to-mouth breath. And rest all the same. But in back mask ventilation, what is important is when you are giving a mask, back mask ventilation, in adult we say that you should give head tilt and chin lift. But in an infant, what happens if you do that, there can be, the airway will not become patent, there can be a compression of the trachea. So it should be in neutral position, means the head of an infant should be at the neutral position as this picture says. And how much should be the breath? Each 2 breaths, that you all know that each breath over 1 second, that's also in adults. In adults, what we say that is the compression ventilation ratio is 30 compression to 2 breaths, So in an infant or a child, when there are two rescuers, what you have to stick on to is 15:2, because the children or the infants, what's happened, they have the respiratory failure, which is going for cardiac failure, and the oxygen content is low in them. So like we have to increase the frequency of your ventilations in an infant and a child. So that is why when there are two rescuers, it is 15:2. Now coming to the defibrillation part, like you know that in adult we are giving 360 joules in a monophasic defibrillator, and if a biphasic we are giving around 200. But in a child, it is according to the weight, it is 2 to 4 joules per kg. Initially you can give 2 joules per kg, and later increasing. And if it is an AED, automated external defibrillator, there are specifications saying that there is an attenuator which will decrease the current. So you have to use AED with attenuator, and the child pals are also available. So this is an attenuator. It decreases the amount, the current of delivering. So in an AED, with having a connection for the attenuator, it will be always be good. And these are the pads. You can easily make out one is an adult pad and a child pad. In a child, they say that more than 80 years or more than 20 kgs, you have to use a child pad, and the placement of the pad, that is also important. Anterior lateral placement is advocated in adults, but if it is an infant, actually it is the anterior posterior placement. The reason being that two pads, because the child is too small, infant is too small, both together actually it will touch each other. So that is the reason why in an infant it is anterior posterior. Now coming to the algorithm, it is almost the same. The first, ensure the safe place, check the response, whether responsive or unresponsive. You can see the green is responsive. So in those patients, you observe the victim and recovery position and shift to the nearest facility if it is responsive. But red is non-responsive, you all know that that is dangerous. So you should shout for help and call that 108 number and ask them to get the AED. Then you have to check the breath and the palpating brachial and femoral pulse and perform within 5 seconds. So you get within 10 minutes you should do all this. So you'll get 3 conditions: normal breathing with definitive pulse. So you put them in the recovery position, reassess every 2 minutes and shift to the nearest facility. Abnormal or no breathing with pulse. So what you have to do is provide one breath every 3 to 5 seconds. In an adult, we say that 5 seconds. Here it is 3 to 5 seconds because they need to have more of the respiratory rate. More rate has to be given. So reassess every 2 minutes. But unlike in adults, you say here, abnormal or no breathing without pulse. And also, if the pulse is less than 60, with the signs of poor perfusion, irrespective of giving ventilation, then you will have to do chest compression. So in adults, it's not like that. When there is no pulse, you are doing. But in an infant and a child, it is like if it is less than 60, irrespective of giving ventilation, adequate ventilation, if there are signs of poor perfusion, then you will have to start chest compression. So that is the difference, and the check pulse every 2 minutes and continue same if there is no pulse. Defibrillator, as I already told you, once you attach it and you have to analyze. While attaching the pads, don't stop chest compression, and while analyzing the rhythm, don't touch the patient, because it will give a false indication to us that there is or to the AED that there is already a compression. If you are compressing, that they think there is already a rhythm. So while analyzing, don't touch the patient. And you know that it's shockable and non-shockable. How you differentiate the earlier class you came to know. And here you have to give one shock, and defibrillation, it is according to the joules per kg, 2 joules per kg, which can be escalated to 4 joules per kg. or you can use AED with attenuator. A non-shockable rhythm, there is no need to give shock, and you have to resume compression. And that is 5 cycles, that is 30 compression to 2 breaths. And if there are 2 rescuers, that is the main difference. If 2 rescuer, you have to increase the frequency of ventilation. It is 15:2. Continue the cycles of CPR till the within becomes responsive. Now this is in a nutshell what I have written in the changes. Hand placement, where you have to place the hand in a infant. It is if it is 2 finger taking or the 2 thumb encircling hands smithing, the brachial pulse has to be palpated in the infant. Now 1 and 2 rescuer, when there are 2 rescuer, it is 15:2 is the ventilation. The depth is 1/3 the anterior posterior diameter of the chest. The ratio of ventilation to the compression when there are 2 rescuer, it is 15:2. Pulse check, where already I have told, defibrillation is 2 joules per kg, that subsequent 4 joules per kg. And the drugs, actually you have, according to the kilogram, like adrenaline, it is 10 microgram per kg, amiodarone 5 milligram per kg, and lignocaine 1 milligram per kg. So these are the changes which are already present. So thank you very much for patient listening.